Hi, this is Jacob Zakarowicz, and for my final project, I decided to research ceramic acetabularums in the next generation of hip resurfacing. Some background on hip resurfacing: it's been around since the 1920s in treating hip arthritis, and it's very similar to the total hip arthroplasty, except that it doesn't involve any femoral stem being inserted into the femur, which allows it to preserve far more bone stock and be a very attractive alternative to those in need of a hip implant. Some issues faced in hip resurfacing today and why the procedure is not more important than a total hip arthroplasty is mainly due to inadequate materials that can't withstand the high loads that the younger, more active population that is getting this procedure is putting onto the hip and its components. Metal on metal bearings were proven to be successful. However, they over time developed high rates of metallysis, which led to the use of metal on highly cross-linked polyethylene, which is what mainly is used today, but it's limited to many females and people with smaller acetabular diameters. And it is a big reason why ceramic shells have been in research, but they've so far have been proven to be unsuccessful due to not being able to withstand the high loads being put onto them. The two new ceramics that are in clinical trial today are the H1 and the Resurf. Both use Biolox Delta as their main component, which is an alumina-based ceramic, and the secondary materials of both of these ceramic acetabular bearings have not been released yet. Some pros and cons of the H1 and the Resurf acetabular components are that they both are primarily composed of Biolux Delta, which has been proven to be very effective in the total hip arthroplasty. Both are going to offer a larger range of diameter sizing, which is going to increase the population pool of people who can get this procedure. H1 has released data on one patient who has had this procedure done, and they've very quickly gotten back to a normal active lifestyle. And Resurf has released similar data, but they have released data on 400 patients who have received this implant, and there have been no negative outcomes to be published as of yet. Cons for both of these acetabular components are that they both lack comprehensive data and they will take decades to develop proper data on their longevity, which is a major issue as the fatigue limit for the ceramic materials are what has been an issue in the past. My criteria for material selections were mainly all ceramic materials in granite EduPack, and then I set limits of both yield strength and compressive strength. For yield strength, I chose 224 megapascals as the minimum limit, and for compressive strength, I chose 209 megapascals for the minimum limit. All the remaining materials after those first two limits were put in place were put on a fracture toughness versus fatigue strength graph. And then I further placed limitations on MRI safe materials, materials with low reactivity with weak acids and alkalis, and a minimum melting point of 110 degrees Fahrenheit. And then I compared the prices of all the materials that were left, and then biocompatibility was taken into consideration with outside research from Granite EduPack. So my initial material selection, I started off with 345 ceramic materials that was offered in level 3 of Granite EduPack. And after I set my first limit of yield strength of 224 megapascals, only 137 materials remained. And after my second limit of compressive strength of 209 megapascals, 135 materials remained. And this figure here is the first fracture toughness versus fatigue strength graph I was able to graph. And as you can see, there are a wide range of materials we have. All of these on the right-hand side are those of tungsten carbide cobalt, and there are different limitations. And we have expensive materials such as diamond and sapphire in this as well, and alumina and zirconia are very prevalent in this graph here. I then set limitations on MRI safe materials, materials whose durability was not affected by weak alkalis or weak acids, a melting point minimum of 110 degrees Fahrenheit. And after all these limitations were put into place, I was left with 56 materials. And this is the fracture toughness versus fatigue strength graph. After that, all of the gray is all of the materials that didn't make it. As we see, all the tungsten carbide cobalt has not been able to meet those limitations, which is one of the main reasons why only 56 materials remained out of this. With the remaining materials, I plotted price per volume cubed in order to limit out the super expensive materials such as diamond and sapphire, which you can see on the top left corner of figure 3. And then I decided to plot Young's modulus, which isn't super important, as the Young's modulus of any ceramic material is much higher than the Young's modulus of the acetabular bone. But I wanted to see if there are any trends or anything that stuck out. As you can see, chromic oxide had a low Young's modulus compared to the others. However, it was still much, much higher than that of the acetabular bone. At this point of my research, 52 materials remained. Beryllia, chromic oxide, and Cylons each took up 1.92% of the materials made up. And the materials made from silicon nitride made up 21.16% of materials. Zirconia made up 11.54% of materials. And then ceramics made of alumina were the most popular in 61.54% of materials. Beryllia, after further research, was quickly eliminated due to its high toxicity, and there is no research being conducted into making it biocompatible. I then decided to do some further research into the remaining materials. I found that chromium oxide is commonly used as a coating in many orthopedic implants in order to prevent the release of chromium ions into the bloodstream, but it itself has never been used as a primary component of any ceramics in any bioengineering settings. Cylon is a silicon nitride alloy with a small percentage of aluminum oxide added for enhanced properties. They have good biocompatibility and favorable features, and there is promising research going into their use in clinical settings, but nothing of implants. Silicon nitride has gained increasing interest in biomedical implants, but further research and clinical studies were shown to be needed in order to test its long-term performance and safety in a biomedical environment. Zirconia has a well-established clinical track record in many biomedical implants, including hip replacements. It is strong, tough, and biocompatible. However, its inability to resist abrasion is a reason why it has failed in hip resurfacing applications. Alumina is by far the most popular ceramic in hip implants. However, its inability to handle high impact forces are reasons why it has failed in the past in hip resurfacing applications. In summary, chromium oxide and Cylon are much less established. Silicon, zirconia, and alumina have all demonstrated success in these applications. However, zirconia and alumina are by far the most respected and most established ceramics used in orthopedic implants, especially in hips. So for this reason, I decided to continue with my research with alumina to compare it to metal and highly cross-linked polyethylene, as it is what is currently being studied today in clinical trials of the H1 and the Resurf. And I think it has the best chance of becoming a acetabular component in hip resurfacing by 2030. So reviewing the mechanical properties of both alumina-based ceramics and metal and highly cross-linked polyethylene acetabular components, uh, alumina-based ceramics have demonstrated long-term success in this field. They have exceptional mechanical properties, including high strength and wear resistance, and they have a historical weakness in handling high-impact forces, which is what has limited them as hip resurfacing implants. Metal and highly cross-linked polyethylene has proven much success in hip resurfacing, especially for younger, more active patients. Has an excellent wear resistance and much adequate strength and durability for handling impact forces. However, its inability to reach those with smaller diameter sizes is a negative. Comparing the biocompatibility of alumina-based implants to metal and highly cross-linked polyethylene, both have been proven to be biocompatible with minimal risks. However, alumina has the ability to shatter, and once it does shatter, it is very hard, almost impossible to pick up the debris surgically, which is a main reason why it has not been popular in the use of hip resurfacing. Alumina-based implants and metal and highly cross-linked polyethylene implants both have a very well-established clinical track record. However, the track record for metal and highly cross-linked polyethylene is much higher and much favorable in hip resurfacing compared to that of alumina-based ceramics. Finally, for my recommendations, I believe that metal and highly cross-linked polyethylene should remain the standard in this procedure until the ceramic materials can prove to not only be strong enough initially, but to be able to last a whole lifetime for these patients without being in risks of fracturing. Chromium oxide, silane, silicon nitride, zirconium, alumina should all be considered in this research for finding a strong enough and suitable ceramic. And the ongoing clinical trials of H1 and Resurf do show promising data. However, until there is no risk in ceramic acetabular components, metal and highly cross-linked polyethylene should be what is used in this procedure. Finally, here are my references, and I thank you so much for listening, and thank you for a great semester, and I hope you have a great day. Thank you. Bye.